Hello. Let's get going again. Wait, just double check. No questions came in. And all right, let's get moving again. Just want to double check. Okay, yeah, that's okay. Clinical guideline update, a focus on acne, immunizations, depression screening, prenatal folic acid supplementation, select STI screening, and more. So we've got a lot to go through as we wrap up the day here in disclosures. No real or potential conflict of interest to disclose. No off-label experimental or investigational use of drugs or devices will be presented. And upon the completion of the learning activity, the participant will be able to A, describe select updated clinical guidelines, B, apply the recommendations of select updated clinical guidelines, and C, identify the pharmacologic implications of these updated clinical guidelines. And references will be throughout and at the end of the presentation. Right, so this, you might say to yourself, well, this isn't exactly new, but the U.S. Preventative Services Task Force did update their recommendation for folic acid supplementation to prevent neural tube defects. So you might be inclined to say to yourself, yeah, it doesn't really apply to my practice. You know, I don't see patients who are coming in saying, I want to get pregnant. So what should I do to maximize the likelihood of a healthy pregnancy? But please keep in mind that in the United States, despite a number of different contraceptive options being available, that we're still close to 50% of all pregnancies being unintended. And that doesn't mean unwanted, but nonetheless, 50% are unintended, and therefore implied in that there was no particular effort made to improve overall health or whatever. And my feeling is I recommend a folic acid supplement and have for years to any person capable of conceiving and carrying a pregnancy who is not using a highly effective form of contraception. So this is the target audience is a person who planned or could become pregnant, any person who could carry a pregnancy, and that recommends that all of these people, just like I have done for a long time, planning to or could become pregnant, take a supplement of folic acid at 0.4 to 0.8 milligrams per day. What you will sometimes hear providers say for women who are actively trying to get pregnant to put them on folic acid, put them on prenatal vitamins, anticipating a pregnancy. And that's not a bad way to do it, but on the other hand, it's a pretty expensive way of providing what is a reasonable dose of folic acid that could be obtained through an over-the-counter multivitamin or something like that. To achieve optimal benefit during pregnancy, the folic acid should start at least 1 month prior to anticipated conception and continue through the first 2 to 3 months of pregnancy. Now, you might say to yourself, why not just continue it throughout the whole pregnancy? Well, part of the reason for this is that if there is folic acid deficiency in the mom, or as we better understand now, some people are genetically folic acid resistant or have difficulty biotransforming folic acid to its metabolite that the body actually utilizes. That you want the supplement on board prior to the pregnancy to correct deficiency, because it's pretty easy to correct. But then continuing it technically beyond the 3rd month of pregnancy in the absence of documented deficiency is not going to be helpful for the prevention of neural tube defect, which is what the target audience here is, reduction in neural tube defect. And the reason for that is the neural tube is all closed up by the 3rd month of pregnancy, actually quite a bit earlier than that. So that's why you want it. That's why the timing is here. So the benefit is folic acid supplementation per the U.S. Preventative Services Task Force provides substantial net benefit in the preventing neural tube defects. And the most common form of neural tube defects are anencephaly, encephalocele, and spina bifida. And out of these, spina bifida is in fact the most common of them. And so trying to avoid those. Keep in mind when the neural tube forms, as I just alluded to it before, the neural plate formation is early in pregnancy, generally about days 26 to 28 post-egg fertilization. And when you think about it, the neural tube starts as a flat sheet of cells, and then it forms a tube, and it closes at the top. That's the brain. It closes at the bottom. That's the base of the spine. And so once the neural tube has closed, the supplement is not helpful at all. So recommendations do not apply to the following: a previous pregnancy affected by neural tube defect or family history of neural tube defect. So if you hear somebody say, my cousin had a baby with spina bifida, my mom lost a baby to anencephaly, this type of thing, and all these folks are genetically related to one another, what you might be actually looking at is a person who has that genetically based resistance to folic acid, doesn't biotransform it properly, and persons taking certain medications known to block the function of folic acid. And so these are meds that are generally not used during pregnancy anyway, but as I said, 50% of all pregnancies are unintended. Would be methotrexate, carbamazepine, Tegretol, valproic acid, a drug like Depakote. So I kind of stepped on this already, but what's the percentage of pregnancies in the US that are unintended? Is it A, 10%, B, 25%, B, 50%, C, D, 75%? And the correct answer, of course, is 50%. I've done this form of the presentation a number of other times. I've had a lot of people go, oh, it's got to be at least 3/4. It was like, no, it's not quite that bad, but it is 50%. All right, so let's move on from that and talk about distinguishing and managing patients with features of both asthma and COPD. So what do we know? People with asthma smoke cigarettes at the exact same rate as non-asthmatics. There is no difference in that, which I think is pretty stunning, given that you would think people with asthma might avoid smoking cigarettes because they've had chronic recurrent difficulty breathing. But no, they smoke cigarettes at the same rate as people with COPD, as people without asthma. COPD is not exclusively caused by tobacco use, but that is the most common risk factor around. So prevalence of both asthma and COPD, it can be seen in up to 55% of patients with either diagnosis, and the prevalence can be based on criteria used, age, and patient's birth gender assignment. Compared to the single diagnosis, the presence of both asthma and COPD is associated with greater burden of symptoms, more frequent exacerbations, poorer quality of life, more rapid decline in lung function, higher mortality, and greater use of healthcare resources. So let's just go over a few different definitions here. Asthma, of course, it's a heterogeneous disease, usually characterized by, sorry about that, chronic airway inflammation and defined by a history of respiratory symptoms such as wheeze, dyspnea, chest tightness, and cough that vary over time and in intensity, along with variable expiratory flow limitation. COPD is also considered to be heterogeneous lung condition characterized by chronic respiratory symptoms like dyspnea, cough, sputum production, and or exacerbation due to abnormalities in the airways, the bronchi, with chronic bronchiolitis common, as well as in the alveoli. So if you're looking at the old terms of chronic bronchitis and emphysema, which we shouldn't be using, we should be using the more inclusive term COPD. The alveoli is where the emphysema are damaged. The bronchitis is where the airways are damaged that are persistent, often progressive with airflow obstruction. And when you've got the two, you've got patients with persistent airflow limitation together with clinical features that are consistent with both asthma and COPD, and it can be called asthma COPD overlap. All right, so when we're looking at history, what are the features that are most likely to be asthma versus most likely to be asthma in COPD? If it's asthma, it is the symptoms vary over time in intensity. So you can have triggers like laughter, exercise, allergens, seasonal, onset before age 40 as a general rule. The symptoms improve spontaneously or with bronchodilators or inhaled corticosteroids, and current asthma diagnosis or maybe a childhood asthma diagnosis. And what would you have for features if you had both asthma and COPD? The symptoms, intermediate or episodic, could have started before age 40 or after age 40, likely has a history of smoking and or other toxic exposures, or a history of low birth weight or respiratory illness. Low birth weight kids tend to have more severe asthma, more airway problems, or a person with a history of something like TB, and then any of the other asthma features that I had already mentioned. Likely to be COPD. There's dyspnea that's persistent on most days, onset after age 40, limitation of physical activity, might have been preceded by cough and sputum, only limited relief with bronchodilator. Remember, chronic obstructive, that's what we have to think of, is the obstruction is chronic. History of that toxin exposure, including tobacco use, no past or current history of asthma, right? And when you're looking at lung function if it's asthma and only asthma, what you will usually have is the variable expiratory airflow limitation. Persistent airflow limitation might be present, but might not. If it's COPD, it's persistent expiratory airflow limitation with or without bronchodilator reversibility. And then if it's the two, you've got the persistent expiratory airflow limitation with or without bronchodilator reversibility. All right, so it's not as clear as it could be, is it? All right, what about spirometry? With spirometry, with the FEV1 to FEC ratio, pre or post bronchodilator, if it's normal pre or post bronchodilator, what you're looking at here is that could be compatible with asthma with reduced post bronchodilator FEV1 FEC ratio. That tends to indicate airflow limitation, but might improve spontaneously on treatment. And just remember, when you're looking at COPD, the FEV1 to FEC ratio will never be normal with COPD, with or without a bronchodilator. It's just not, okay? So that's going to be helpful there. And when you've got the asthma COPD overlap, ditto, right? And that reduced post-bronchodilator FEV1 to FEC ratio of less than 0.7, that is required for the diagnosis of COPD. So one of the things that you're really looking for here and looking at the spirometric type of evaluation, what you're seeing is with COPD, the readings are fixed and they don't improve, right? With asthma, they can be really quite variable on that one. So more of this is just giving you an idea of how much a bronchodilator will increase FEV1 from baseline, and you're going to get a lot more increase in FEV1 from baseline with bronchodilator. In a person with asthma, it would be unusual in COPD, but you're going to get something in the middle with the person who has the asthma COPD overlap. Right. So what about pharmacologic therapy? If it's highly likely to be asthma, an inhaled corticosteroid-containing treatment is essential to reduce the risk of severe exacerbations and death. And Gina Track 1 says an ICS, inhaled corticosteroid with formoterol as reliever therapy is the preferred regimen. Never give a LABA with and a LAMA or a LAMA without an inhaled corticosteroid. And maintenance oral corticosteroids with asthma are as a last resort. Okay. What about looking at the person who has both asthma and COPD? You need to stick to the inhaled corticosteroid containing treatment as essential to reduce the risk of severe exacerbations of death. That's from the asthma component there. Add on a LABA and or a LAMA is usually needed. Don't give the LABA and or the LAMA without an ICS. Same thing with the corticosteroids. So one more time, what do we have is with COPD by itself, we're not routinely adding the inhaled corticosteroid. We're doing more things like when it's COPD alone, LABA, LAMA therapy. With COPD alone, add the inhaled corticosteroid per the GOLD recommendations in patients who have hospitalizations, 2 or more exacerbations per year requiring oral corticosteroids or blood eosinophils of 300 or greater. And that you want to avoid high dose inhaled corticosteroid and avoid maintenance oral corticosteroids. And a reliever therapy that includes an inhaled corticosteroid is not recommended if it's COPD alone. But what do we know? In people with asthma, the concept of SMART therapy, single maintenance and reliever therapy, has been around for a few years now, using a low dose inhaled corticosteroid with a LABA as both a reliever drug and as a prevention drug to prevent asthma symptoms, needs to be part of people with that COPD asthma overlap, like it would be with a person who is simply has asthma. It really does need to be there. And the one, I believe you are aware of this, that's most likely recommended is low dose budesonide with formoterol. And that's brand name Symbicort, although it's been generic for a number of years now, but still a lot of people will just cut it short and call it Symbicort. And the reason for that as the preferred controller therapy as well as reliever therapy in asthma plus asthma with COPD is because formoterol kicks in a little quicker than salmeterol does. So that's why there is that recommendation. One way of remembering that is formoterol starts with the letter F, F for fast. It's not that fast, but it's faster than like a salmeterol or something along those lines. Okay. Now, acne vulgaris, the American Academy of Dermatology came out with newer guidelines for this during 2024. And let's take a look at acne vulgaris, the pathogenesis. It's multifactorial. It's follicular hyperkeratinization, microbial colonization with the C. acnes organism, sebum production. It's a complex inflammatory mechanisms. There's a neuroendocrine component to it, and then likely some genetic and non-genetic factors. About 85% of all teens will have significant acne. And actually, very few of them get treated for it by a healthcare provider. More likely than anything, what they do is kind of tough it out, which I think is just heartbreaking. 20% of all kids will end up with severe acne and subsequent scarring. And I make it sound like it's only teenagers, and I have to stop doing that because obviously the kind of acne that we think of when we think of teens, it can continue well into the 20s and perhaps beyond that. And it affects areas of the skin where sebaceous follicles are located, like the face, the upper chest, and the back, sometimes the upper arms as well. What are one of the key concepts with acne vulgaris therapy, regardless of what the therapy is that all acne therapies take about 6 to 8 weeks of use prior to seeing significant clinical effect. The way I describe this to the teens, if that's who I'm seeing, is that pimple on your skin now started forming a month to 2 months ago, and we're just seeing it now. So what we have to do is have you grow another crop of skin that is free from lesions that are developing. Topical therapy should not be just used on the spots, because that's when you get a lot of people saying, but the medicine didn't work, because they're taking a dab and putting it on a formed pimple or other lesion. And what they need to be doing is over the entire skin region, because you're trying to prevent stuff. You actually can't do a whole lot for acne lesions that are already on the skin. What you have to do is try to prevent the development of new ones. All right, so what have been some treatment options for the treatment in acne? Well, one of them that's been around for practically forever is topical benzoyl peroxide. It's antibacterial. What's interesting is it's been around for years, but the organism, the C. acnes organism that contributes the bacterial part to acne has not developed resistance to it. So that's good. It's cheap, available over the counter, most helpful though in mild acne, usually with something like a keratolytic acne wash with 2% salicylic acid. And there are a number of those formulations that are available. Now, one of the things is if you were ever walk through the aisle in a retail pharmacy at the acne products, you'll see like Oxy 10 or maximum strength, that type of thing. And the highest percentage of benzoyl peroxide that can be sold OTC is 10%. But 2.5% works just as well as 10% and doesn't irritate the skin as much. All right, so lower concentration in water-based or wash-off formulations are much better tolerated. There's a lot less redness. And if the 10%, it was a matter of, we'll put up with the redness because it's going to make your skin that much better, that much quicker, that'd be one thing, but there really is no coming back and saying, yeah, it's going to be a whole lot better if you use that higher percentage. Now, the topical retinoids, including things like tretinoin, products like Differin, products like Retin-A, things along those lines. And they are good condymolytic, significant anti-inflammatory effect. These really should be considered for all acne types. And with initial use, they're pretty tough on the skin, but that improves over time. And this is, I'm privileged to have practiced in a predominantly Latino community. So most of my patients are African Caribbean ancestry. So most of them have a darker skin tone. And I can't tell you the number of times I've said to somebody that I have advised to use a topical retinoid, maybe written the prescription. I'll say, you need sunscreen. And they'll go, I don't sunburn. I'll say, please, please, listen to me, use the sunscreen. And then they'll come back sometimes and sheepishly say, well, I thought you were crazy talking about sunscreen. I've never used sunscreen, so I don't sunburn. I went to the beach and I sunburned. I'll say, yeah, highly, highly photosensitizing. highly photosensitizing. So to give you some of the different formulations, by the way, adaptolin is a topical retinoid, and that is sold over the counter. It's pretty pricey. Yes, you could just tell your patient, go and buy the over-the-counter adaptolin. They'll be better off buying a tube of generic prescription topical retinoid. That's going to keep the cost way down. Now, what about topical antibiotics like clindamycin, erythromycin, dapsone? There are a whole bunch of others. These are antibacterial and anti-inflammatory, but putting an antibiotic just on the skin, that really only works with milder acne and is less effective than oral antibiotics in moderate to severe acne. And some of you might have heard me speak over the years, and I am a zealot about not overusing antibiotics. I really am. I have zero problem prescribing an oral antibiotic for a teen or a younger adult with moderate to severe acne. None, because I know it's going to work. And I also know it's going to be long-term. I also know, like, probably 6 months, a year, something like that, maybe even longer. I also know that it increases that young person's risk for carriage of resistant pathogen. And I kind of don't care. And the reason why, I don't want to sound flippant with that comment, but what I want these kids to do is look and feel better. Look and feel better. So that's why I really don't have much in the way of of holding back on the oral antibiotics. However, the topical antibiotics work pretty well if you help the younger person get the skin under control with the oral antibiotics and then switch over to like a benzoyl peroxide retinoid topical antibiotic combination. And that can be really helpful. Do not use the antibacterials as monotherapy, like that's it, because of the risk of antibiotic resistance, particularly with clindamycin, but clindamycin with benzoyl peroxide, so it's antibacterial from 2 different ways. That's a possibility. There is a prescription drug that does both of those. Now, oral antibiotics like doxy, minocycline, erythromycin, trimethoprim sulfamethoxazole, azithromycin, I kind of gave my little speech on those already. Great antibacterial, great anti-inflammatory, and indicated for the treatment of moderate to severe acne. Remember, tetracyclines like doxy, we want to avoid during pregnancy, lactation, and in kids under the age of 9 years. Usually you aren't treating acne in kids that young. Concomitant topical therapy can also be recommended with that. And then once the skin improves, usually after 3 to 4 months of continuous therapy, you could taper off slowly while adding the topical antibiotic. And rapid discontinuation leads to the acne going back to pre-treatment baseline, and non-long-term or repeat therapy is often needed. Now, I said before, it could be a year, 2 years, whatever. What is not at all uncommon with treating folks with moderate to severe acne is the following. 3 months on the oral antibiotic, the skin looks great. You've added in the topical, you're using a retinoid, everything's good. 3 months later, the skin starts to look really problematic again. They go back on another 3 months of the oral. 3 months off, the skin is acting up again. So very commonly, that's what's happening with the treatment of acne. Honestly, what I find is if you put a teen, a young adult on oral antibiotics for acne therapy, generally they take themselves off after about 3 months. They just do kind of a self-taper, not a taper, but an abrupt cessation. And the reason they do that is they say, oh, look, my skin looks much better than it did before. And then they come back a few months later and they need to go back on the oral. All right, now the combined estrogen progestin hormonal contraception in either pill, patch, or ring form, or the drug spironolactone, these can be used to reduce androgen levels by increasing, with the estrogen in particular, that's going to increase sex hormone binding globulin. And the spironolactone works by being an androgen blocker and decrease sebum production. These should only be used in female birth sex assignment with moderate to severe acne, not in males, but even the spironolactone. You know, birth control pills, that kind of makes sense, right? But the spironolactone, it is tempting to use it in male birth sex assignment. Don't do it because it is an androgen blocker. And what do you notice among people with particularly severe acne? You tend to notice that it is really severe acne is found more in males than in females. And that is because males have higher levels of androgens, right? And if you're saying, yeah, but if maybe a male teen with severe acne, maybe that's a particularly high testosterone state, why don't we just block some of that with the use of spironolactone? Remember, spironolactone is one of the first drugs used for male to female gender affirming therapy. And so we know it, if you give enough of it, it does a really good job of blocking androgens. So that's not considered to be standard of care. And about 3 months of continuous use is needed prior to findings to significant acne improvement. By the way, on the birth control pills, patch or ring, all of them will work. All of them will work because it is the estrogen that's helpful at boosting sex hormone binding globulins, okay? With discontinuation, just like the antimicrobials, the acne is going to return to its baseline, and start the topical therapies, maybe even the oral aid at the same time. Now, this is something that is a newer therapy. The brand name is Winlevi, and it's a topical anti-androgen. And it reduces the androgen levels, decreases sebum production, can be used, matters not for sex assignment. It is pretty pricey. It is pretty pricey. And that, since the last time the acne guidelines were updated, this was the what has been added on next. All right, how about Accutane? Mechanism of action, interestingly enough, is not well understood. And it's indicated for the treatment of severe nodular acne that does not respond to other therapies like the oral antibiotics and the topical retinoids. Usually is given for 4 to 6 months, and it's discontinued when the nodule count is reduced by 70%. Repeat the course only if needed after 2 months off the medication. And there is a boxed warning with the use of Accutane about mood destabilization and or suicidal thoughts. It's there. The FDA put this on there many years ago, 15, 20 years ago. And most providers who prescribe Accutane do not believe that it is valid, but it's there, and therefore this is part of informed consent. And one of the things is, like, I'm not an Accutane prescriber. I might have the occasion to prescribe it every couple of years, maybe. And by the time I'm thinking Accutane for somebody with acne, I'm thinking they should be seen by dermatology. Now, I am very fortunate that we actually have derm in our community that sees people in a relatively reasonable length of time. But you might look at a patient and say, oh, this is nodular cystic acne. I'm just going to not bother treating them. I'm going to send them to derm. They'll have to wait 6 months. But that's okay. This person has looked like this for 3 years now. You know what you want to do? Get them on the oral antibiotics and the topical retinoid, because otherwise that's probably where derm will start them anyway. And then give them a number of months of that therapy, they'll probably get a little bit better with it. But what it will do is demonstrate to derm that, yeah, this is a person who needs Accutane. So what you have to do is be a certified Accutane prescriber in order to prescribe it, because this is one of the most teratogenic drugs available on the US market. And females of childbirth, bearing age must use two types of highly effective form of contraception for 1 month before, during, and 1 month after the use of the Accutane. And I've had some young women say to me, well, I don't have sex, so I don't need to worry about birth control. And I'll say, that's one highly effective form of contraception. We need to get a second one on board. And you might as well take advantage of the fact that the combined hormonal contraceptive could be helpful in relieving some of the acne signs and symptoms anyway, and use that. All right, what's the global assessment of acne severity? And I look at this and I go, it's kind of a little bit, a bit on the subjective side to a certain degree. But one of the things is that an assessment of acne severity is needed for something along these lines in order to do inclusion-exclusion criteria of who can be in clinical trials and the like. So 0 is clear, no lesions. 1 is almost clear, rare comedones with more than one small inflammatory lesion. So what you could do is document as well when people are improving. They started off as a 3 and they're down to a 1. That's great. Nice documentation there. Mild, a 2 would be mild, some comedones, and no more than a few inflammatory lesions, papules and pustules only. 3, moderate, many comedones, papules, pustules, 1 nodule might be present. And severe is, or 4 is many comedones, papules and pustules, and a few nodular lesions, right? So with the latest guidelines, acne type mild, the preferred therapy, topical retinoids, topical antibiotic, topical benzoyl peroxide, and combining multiple topical therapies with multiple mechanisms of action is recommended. So, use all 3 of those, be my guest. And there are some particularly prescription products that will combine a lot of things, like the topical antibiotic, Clinda plus benzoyl peroxide is very commonly used. And then the retinoid would be a separate topical med. Moderate to severe, you want to have the topical therapies like a retinoid, a topical antimicrobial, benzoyl peroxide, plus a systemic antibiotic. And after 3+ months, often able to transition to topical therapies only. And when first-line therapies are not tolerated or less than desired clinical effect, the next step would be in conjunction with the previously mentioned therapy. So hormonal agents like female birth sex assignment, birth control pills, spironolactone, or the topical anti-androgen, regardless of birth sex assignment. And you can even get into intralesional corticosteroid therapy for the larger nodules. The severe acne for those who have failed, or even those who have failed standard treatment with oral or topical therapy. And conditional recommendations are used for the use of a topical anti-androgen, salicylic acid, azelaic acid, oral minocycline, and a few other products there, as well as spironolactone. Couple of things to keep in mind with the antibiotics, the oral antibiotics. Minocycline historically has been advocated over doxycycline, but when you get right down to it, you look at the issue is doxy inferior to the use of minocycline. It's really kind of comes out in the wash that they're about the same. and that oral Accutane is a strong recommendation for severe acne, acne causing psychosocial burden or scarring, or acne failing to respond to standard treatment with the oral or topical therapy. These guidelines, when you dig through them, they're really very forward on saying the following. Too many people are suffering needlessly with acne, and we've got Accutane, and it can be a very, very helpful product. The other thing is too many people are suffering needlessly with acne when an oral antibiotic could take care of it. So going back to the oral antibiotics, I'm not a big fan of azithromycin. I'm just not, because for things like otitis media, ABRS, etc., its strep pneumo coverage is poor. It's unfortunately got worn out after 25 years on the market, because it was so easy to prescribe and so well tolerated that, prescribers were giving it to people who would just come in and say, I've got a 1.5 day of sore throat and runny nose. I know my body. I've got a sinus infection. It's like, here's your Z-Pak, go along. We know that happens. It shouldn't happen, but it does happen. And to a certain degree, I understand that, because productivity being what it is, one of the quickest ways to move a sick visit through your exam room is just give them the antibiotic. I understand that. There have even been studies on urgent care providers that demonstrate over a 12-hour shift, their antibiotic prescribing practices get less evidence-based as the hours go by. I always think as the hours go by and the people stack up in the waiting room. Yeah, I understand that. But on the other hand, there are some times when azithromycin can work, and it actually is a therapy that's in the AAD guidelines. It's a non-teratogenic antibiotic. So if you were to give it to a person capable of conceiving and carrying a pregnancy for the treatment of acne, and this person's not contracepting on a regular basis, you don't have the teratogenic risk that you could have with doxycycline or minocycline. Another benefit, it's 1 pill every 5 days. So it's azithromycin, 500 milligrams, 1 pill every 5 days. That is an off-label use of azithromycin. I need to make sure I say that. And if you're saying, how the heck will you ever get the pharmacy to fill that? What I do is I send it into the pharmacy at azithromycin, 500 milligrams, 1 tablet every 5 days for the treatment of skin infection. I've never had it rejected by the pharmacy. I've never had a pharmacist call me up and say, what the heck kind of skin infection are you treating? But acne is a skin infection, is it not? Well, it's part of it, but it's just something to keep in mind. All right, CDC this year updated its respiratory virus recommendation, and you can see the link to it here. And what did they say? And why these recommendations is adopting a unified approach to limiting respiratory tract disease spread makes these recommendations easier to follow and is more likely to be adopted, and does not rely on individuals to test for illness, a practice that data indicates is really uneven. I've heard people say, had people say this directly to my face. I've got COVID tests at home. I'm not testing for COVID. I don't want to know if I have COVID, because I don't want to have to stay home and miss the, the family reunion or the whatever they're going to. And so I understand this, but this is what the CDC says to protect all of us. When people get sick with a respiratory tract infection, CDC recommends stay home and away from others. Easier said than done, right? For people with COVID-19 or influenza, specific treatment is available and can lessen symptoms and lower the risk of severe disease. We know that. For a person with a respiratory illness can return to normal activities when symptoms are overall improving. for 24 hours or more if fever has been present is resolved without the use of a fever-reducing medication. And after resuming normal activities for 5 days, curb disease, hygiene practices, so good hand washing and the like, wearing a well-fitting mask, keeping distance from others, and making effort for cleaner air. So in other words, you only have to stay home until you're feeling somewhat better and without fever. And then you can go back to normal activities, but it is recommended that the person wear a well-fitting mask. They're not bad guidelines. They really aren't. And why not hide out, isolate for a longer period of time with COVID, particularly for people who don't feel that sick, but they know they've got COVID. Part of this is just the recognition that there probably are a lot more people roaming around with COVID, and we just don't know. And the reason we just don't know is because people are not testing and they're not coming in for testing. That's what it boils down to. Now, update on COVID-19 vaccination. And so, and this was updated August of this year. And keep in mind, the full name of the virus that causes COVID-19 is the novel SARS-CoV-2, okay, coronavirus 2, novel. That the word novel means no one ever saw this virus before, okay? Yeah, we had seen SARS-CoV-1 about 20 years ago that was limited to certain parts of Asia and kind of burnt itself out, in part due to some pretty draconian isolation and public health policies, but it burnt itself out. Haven't seen it since then. But SARS-CoV-2, I have to say, when I first started hearing about COVID-19 in very, very late 2019 into early 2020, before it really hit the United States full force, I remember thinking to myself, yeah, it's going to be like the SARS-CoV-1. It'll burn itself out. Little did I know, right? That was my thought. So since we know this is a very different virus, we know information about this virus and its resulting diseases is evolving. And truth be told, the acceptance of the RSV vaccine for adults has been less than robust. The acceptance of the latest iteration of the COVID-19 vaccine has been way less than robust. And one part about this is, unfortunately, there has been a general thought in the greater population. People are saying that they've got vaccine fatigue. Unfortunately, some not accurate information about vaccine safety and that type of thing. So, but we're going to learn more about this. And I will tell you one thing. With the COVID-19 virus, if we still had the original variant rolling around like we did in 2020, we'd still be all masked up and staying in our homes for the most part. We would be, because it was a much more virulent viral form than the one we've got now. And one thing about viruses is they will all change over time, or I should say, most of them will change over time. It is not to a virus's benefit to kill off most of the people it infects, because then it runs out of hosts. And that's one reason why the current iterations, current variants now, are highly contagious, more contagious than the original variants, but not nearly as capable of causing severe disease as the original COVID-19. And what percentage of US adults have evidence of COVID-19 antibodies from either disease, vaccine, or both? It's at least 98%. So it's virtually been a 100% population saturation. And that's one reason why we're seeing people come down with COVID-19 but they're just not as sick as they were before. Even if they've not been immunized, they've not gone on antivirals, because what they're doing is their body is now familiar with this virus. Familiar. About 15% of the adult population has never had a vaccine, never had a vaccine against COVID-19. And there is that small population that appeared to never have had COVID, that at least not clinically evident, but virtually all of them have evidence that they've had antibodies. So we have to remember that upwards to 50% of COVID's cases are really subclinical. Few things that haven't changed about immunization against COVID-19. There are very few contraindications. People age 6 months and up, nearly everyone is eligible. What has changed in the vaccine, or what is in the vaccine, has changed over time and will continue to change. And that in June of 2024, the 2024-2025 COVID formulation of the vaccine was announced being available in fall of this year. It was actually September of this year. But what's in the vaccine? Well, what I could tell you is no preservatives, no antibiotics, no latex, no tissue, no fetal or other cells, no food proteins, no eggs, peanuts or others, no metals, no mercury, nothing along those lines. So yes or no, the risk of dying from COVID-19 among unvaccinated adults compared with adults who received a primary series was 9 times higher for adults age 65 to 79 years and 4 times higher for adults age 80 plus years. Yes or no? And that's yes. So in other words, unimmunized adults have a much higher rate of dying from COVID than immunized adults. COVID-19 vaccination was associated with a 90% reduction in for risk of severe COVID-19 outcomes, including invasive mechanical ventilation in inpatient hospital death across all variant periods, regardless of age. Yes or no? And that is yes. Okay. So how many COVID vaccine doses are there? Does a person need, and which vaccines? So at the very beginning, it was really clear you had that 2-shot series, and then everything evolved from that. So the number of recommended COVID vaccine doses varies by age, vaccination history, and the presence of moderate to severe immunocompromise. In other words, there is zero one-size-fits-all on who gets COVID vaccine and how many doses they get. So it has to be figured out individually. And so what there is here is a link to the COVID-19 immunization schedule for people age 6 months and older. And the CDC strongly recommends everybody 6 months of age or older, whether or not they've previously been vaccinated against the COVID-19, they should receive the updated 2024-2025 vaccine. I got it, dragged my husband along to get it. Everybody in my family has received this. And so some resources for updated treatment protocols in COVID-19. There are 2 really good sources. My favorite source is no longer being updated, and it was called COVID Protocols, and it was an app, but the agencies that were supplying that in the earlier pandemic they've just made the decision not to keep it updated because there are other resources now. But the Sanford Guide, always great on that. And COVID-19 treatment clinical care for outpatients. That's where I live, is in the outpatient setting. I gave you the link to that there, but not a whole lot of new stuff. Remdesivir, and Paxlovid preferred, molnupiravir if you can't use Paxlovid, and you want an oral option, particularly if there are interacting drugs, that the Paxlovid, the patient's taking an interacting drug that you can't discontinue. Paxlovid could get them into trouble, but molnupiravir has pretty much no interactions. Okay, what about pneumococcal vaccine general update? And there are two types of pneumococcal vaccine. There's pneumococcal polysaccharide vaccine, or PPSV 23. This is old school Pneumovax. It's been around for 30 plus years. And it's T cell independent, short-lived immunity, no immunogenicity in kids younger than 2 years, no real booster effect with it. And then there's pneumococcal conjugate vaccine. And that the conjugate vaccine, the PCV, these are the Prevnar forms, chemically added, adding a protein. It's T cell dependent immunity. And simply put, conjugate vaccines make a person mount a more robust immunologic response than a polysaccharide vaccine. And it will work in kids under the age of 2 years, right? And so, as I said, conjugate vaccines will give you a more robust immunologic response than a polysaccharide vaccine. And we started off, the first conjugate vaccine in the market was PCV 7, and then it was 13, then it went to 15, and now we've got PCV 20 and PCV 21. So it can target certain prevalent serotypes, addressing serotype shift in replacement. There are opportunity to simplify the recommendations and impact on disease. This needs to be monitored over time, how much of a difference it makes. So here are the different vaccines, right? I feel like I need to say this just in case we've got an NP student on board here, is no, you don't need to memorize this for the boards. But this gives you an idea of the serotypes or the different parts of the pneumococcal vaccine, what covers what. I know it is mind-blowing. And the PCV 21, which is the newest pneumococcal vaccine, contains 11 serotypes that are not included in PCV 20 and 8 serotypes that are not included in any other vaccine. So this PCV 21 is the latest pneumococcal vaccine. It was approved like June of 2021. And the approval was based on 3-phase clinical trials demonstrating safety and immunogenicity of the vaccine in adults aged 50 years and older. And it is, I'll be honest with you, it's ongoing study to see what the real world benefits of this vaccine will be. And that it includes 8 serotypes not covered by any other pneumococcal vaccine. And that's responsible for 30% or more of invasive pneumococcal disease among adults age 65 years and older. And so ACIP came up with the recommendation for PCV 21 as an option for adults age 19 years and older who currently have a recommendation for to receive a dose of a pneumococcal conjugate vaccine. All right, this is what happened, because there are recommendations. When you look at the vaccine schedule for people, and let's kind of keep it simple, to people age 65 years and older who have never had pneumococcal vaccine before. Okay, they don't have COPD, they don't have asthma, they don't have anything. And so there has been a lot of hand-wringing over this. Do they need a pneumococcal and then you booster them or give them later on a Prevnar? Do you use just a plain Prevnar, and do you use a 15, a 20, a 21? What about the person that got a Pneumovax 15 years ago because the person has asthma, and it is recommended that people with asthma receive pneumococcal vaccine because they tend to get more severe pneumonia, et cetera, et cetera. Oh, they got Pneumovax in the past. How long do you have to wait before you give them Prevnar? I mean, it's mind-boggling. Oh, they got Prevnar 13 and a Pneumovax. What do we do now? Do we give them a 21? So what the CDC actually did was they developed an app. They developed an app. You can download it here. And what it will do is you just plug in the patient information and it will tell you what to do next. So the days of just glancing at a table and going, oh, that's what the person needs, they're gone, because this is just so confusing. So I'm not going to rattle off the if this, then that, because I think I'm going to make your head spin if I do that. But this app is really very, very, very fun to work with and really enlightening, right? Now, what about the U.S. Preventative Services Task Force recommendation on depression and suicide risk in adults? What are the screening recommendations? So remember, with the U.S. Preventative Services Task Force, they're pretty militant that something needs to show significant benefit before they're going to say, yep, add it to the guidelines. So this is what they say. The U.S. Preventative Services Task Force concludes with moderate certainty that screening for MDD, major depressive disorder, in adults, including pregnant and postpartum persons, as well as older adults, has a moderate net benefit. And remember what a true screening test is. A true screening test is when the person has few, if any, signs of symptoms of a disease, and or maybe no signs or symptoms of the disease, but you discover they have the disease. So this is true screening. That's what we're talking about here. And that they conclude that on the current evidence is insufficient to assess for the balance and harms of screening for suicide risk in the adult population, including pregnant postpartum persons as well as older adults. So they're not standing by there and saying that we've got evidence that screening for suicide routinely is helpful, but screening for depression is in fact helpful. Now, what's the rationale for MDD screening recommendations in adults? That there is moderate benefit, convincing evidence that treatment such as psychotherapy or pharmacotherapy for the treatment of depression in improved health outcomes is associated with a magnitude of moderate benefit. And similar outcomes are seen in older adults, less evidence in the treatment during pregnancy and postpartum. All right. So, and obviously then positive screen, go ahead and treat. Okay, so let's take a look at the ACC expert consensus decision pathway for the treatment of heart failure with reduced ejection fraction. And that, first of all, what they encourage us to do is to make sure that the person with heart failure is appropriately staged. So stage A is at risk for heart failure without symptoms, no structural heart disease or cardiac biomarkers. Stage B, structural heart disease, like there might be left ventricular hypertrophy, but no prior or current signs or symptoms of heart failure. Stage C, structural heart disease with prior or current symptoms of heart failure. Stage D, marked heart failure symptoms that interfere with daily life, recurrent hospitalizations, despite attempts to optimize guideline-directed medical therapy, right? So what I'm going to do is talk about more the stage C and stage D therapies, because if you're really interested in diving deeper in these guidelines are really good. So initial treatment of reduced ejection fraction heart failure, stage C, is a renin-angiotensin blocker. So that could include something like the ARNI-ARB combination, right, Entresto, and the ARNI is the preferred agent. ACE inhibitor or ARBs as solo therapy should only be considered in patients with contraindication, intolerance, or inaccessibility to ARNIs. ARNIs are drugs that cause an offloading of some sodium and some fluid, very helpful. And so an ACE inhibitor or an ARB is solo therapy only when a product like Entresto that has an ARNI plus an ARB and it cannot be used. You should also have on board beta blocker therapy with carvedilol, which is a non-cardioselective beta blocker. So it blocks against beta 1, beta 2, and alpha 1 blockers. So it also causes a lowering of the blood pressure more than a standard beta blocker, but avoid carvedilol in a person with COPD because of the beta 2 blockade in the airways. And then bisoprolol or metoprolol. Metoprolol is very commonly used in people who have underlying lung disease of some kind. And so additional therapy should include for reduced ejection heart failure stage 3 is a sodium glucose cotransporter inhibitor. And this would be one of the gliflozin drugs. Now, this is recommended whether a person has diabetes or not. And so this could be dapagliflozin, empagliflozin, or sotagliflozin. Those are the ones that have been best studied in heart failure. And then mineral corticoreceptor antagonist therapy, MRA therapy, like spironolactone is advised as well because that helps with fluid management. And when guideline-directed medical therapy is not enough, with persistent volume overload, titrate diuretic therapy, persistently symptomatic people of African ancestry, despite GTMT or New York Heart Association functional classes 3 to 4, add hydralazine and add a hydralazine, a very old high blood pressure med, and a nitrate. And this is noted to be helpful specifically in people of African ancestry. Resting heart rate of 70 or greater on maximally tolerated beta blocker dose in sinus rhythm with, again, New York Heart Association functional class 2 through 3. Add a rate lowering product in high risk patients already on optimal guideline therapy with worsening heart failure as evidenced by heart failure hospitalization and or requiring IV diuretics. And this is another product that has been known to minimize the risk of heart failure exacerbation. And what these guidelines say is we really do need to look in it is that medication non-adherence is often the reason why people with reduced ejection heart failure are so symptomatic. And it's 20 to 50% of patients are non-adherence. And non-adherence rates do differ by drug class, is associated with worse outcomes in heart failure. And many patients also do not receive target or maximally tolerated doses of recommended therapies. And, you know, as I just rattled off like 9 bazillion meds that these folks should be on, and I'm going to talk about adherence. Whenever you can get it down to a once a day drug, that is the way to go. So medication adherence rates at 1 year with the med class without a prior worsening heart failure event, almost 3/4 of the people are actually taking it. But if they have a worsening heart failure event, it's only about 2/3 are actually taking it the way they were advised. With an ARNI, and remember, it's always an ARNI with the ARB. It's the drug Entresto. A little bit more than 60% adherence with worsening heart failure event. It's down to 53%. And for the MRAs, it is about 60% without a worsening heart failure event, and a little bit less than half if they have a worsening heart failure event. So what are some of the reasons for non-adherence? Socioeconomic factors, difficult access to the pharmacy, lack of social support, homelessness, poor communication within the healthcare system, silos of cares. Oh my God, we could just go on for like 5 days on silos of cares. No automatic refills. So whenever you can, do automatic refills on behalf of the patient. Difficulty navigating patient assistance programs, the unaffordability of the cost of care, and patient factors, perceived lack of effect. You know, you get told by a provider, take these different meds. You're on 6 different meds, maybe even 8 different meds, and you still feel rotten. So why should the person think, oh, I'm going to get a lot better on these meds? Poor health literacy, disabilities, mental health issues, social isolation, cognitive impairment. And one more, just because it needs to be said. Frequency of dosing is often a big issue, polypharmacy, adverse effects, and that how complex heart failure regimens are, impact of comorbidities, and then, you know, you hardly ever see somebody with heart failure who only has heart failure going on with them. They usually have major polypharmacy because of their multiple comorbidities. All right, so we're going to wrap up now and talk about guidelines for screening and treatment of Mycoplasma genitalium. You're going to hear this called more and more MGen, and this comes from the CDC. So what does Mycoplasma genitalium cause? An assigned female at birth, cervicitis, urethritis, PID, preterm delivery, spontaneous abortion, and infertility. There is a hypothesis that's attempting to be backed up with some actual research that perhaps upwards to 30% of couples experiencing infertility, that MGEM might be contributing to it. An assigned male at birth, symptomatic urethritis, asymptomatic urethritis, persistent urethritis, and about 40%. Now remember, we tend not to routinely test for Mycoplasma genitalium. We don't, okay? Is there testing around? Yes, there is NAT testing, the nucleoside amplification, acid amplification test, like similar technology to what we use to test for GC chlamydia. And so that technology is available. Urine testing works in male. If you're going to do NAT testing in females, it is preferred that it is a vaginal swab, okay? And what about standard culture? It's slow growing. It takes special handling. It would have to go to a special lab, and it could take 6 months for the culture to grow out. No, that sounds pretty unacceptable, doesn't it? And sensitivity, however, there are regional studies being done with public health departments and the like, because there's a fear that Mycoplasma genitalium, there's more and more resistance to standard antimicrobials to this. So who should be tested now? I think sooner or later we're going to get one of those advisories, like the advisory that we have with chlamydia and GC, you know, about particularly females under age 25 years and younger, do routine screening on them, and then select in male sex assignment screening in that group as well. And certainly, who should we test? We should test anyone with recurrent urethritis and cervicitis post-treatment failure, and consider this in pelvic inflammatory disease. Obviously, partners of individuals with documented MGen. I don't know if this has happened to you guys, but it's happened to me countless times over the years. I've had a patient who comes in maybe with some vaginal discharge, maybe not. Also could just be a person due for a PAP. And I open up the speculum, and this red raw cervix is looking at me, okay? So I test, because common diseases occur commonly, for GC and chlamydia, because those are the most common. I presumptively treat for with like doxycycline for cervicitis, because chlamydia is far more common than gonorrheal infection. Get back the results, it's negative for both, okay? Bring the person back for whatever reason, take another look at the cervix, it's as smooth as silk. That looks fine. So the doxy did the trick. on the cervicitis, cleared it up. But what was the bug? So this could well be that bug that you see when a person presents with a cervicitis or urethritis, but everything tests negative, negative, negative. So routine screening, as I said, not yet recommended. If you've got MGen documented, because you have to do special testing for this, and sensitivities, your regional sensitivities are not available. You do doxycycline 100 milligrams PO twice a day for 7 days. That reduces MGen burden. The current recommendations now are to follow that with a week of moxifloxacin, 400 milligrams orally once a day for 7 days. And the reason for that is the concern about the MGen growing resistance to doxycycline, but then the moxie will kind of come in and clean up and take care of this. I know it's very odd, isn't it? Okay. If MGen sensitivity is available in macrolide sensitive, you can go with doxycycline 100 milligrams orally twice a day for 7 days, just like we would treat chlamydia. And that reduces the MGen burden, followed by azithromycin 1 gram orally as the initial dose, followed by 500 milligrams orally once a day for 3 additional days. And that's 2.5 grams. And that will take care of that. And that increases the likelihood of the MGen eradication. And if MGen sensitivity available and macrolide resistance, we go with the regimen that I said first, the doxy followed by the moxifloxacin. All right. One of the things that we need to keep in mind for MGen during pregnancy, we definitely don't use doxy during pregnancy, and try to steer clear of the fluoroquinolones as well. If I go way back to the old pregnancy risk category of A, B, C, and D, and I know I'm not supposed to, but I'm going to do it anyway, that the fluoroquinolones are category C because there has been cartilaginous issues noted in laboratory animals exposed in the womb to the fluoroquinolones. That has not been noted in human population. You get expert consultation from the CDC. Sex partners of individuals with known MGen use the same treatment regimen as you did with the partner. Is test of cure recommended? It's not advised, but consider retesting with sensitivity if the symptoms persist post recommended therapy, particularly if partner was also treated. So I want to thank you for your time and attention. See, we've got a couple of questions that came in, or maybe just a question. I was a pediatric clinical at the very start of COVID. The doctor was an older Eastern European doctor. She immediately began isolating patients with symptoms, asked about travel, and started initial assessment in the patient's car before entering the clinic. She had staff wearing masks. She was way ahead of any CDC guidelines. Yeah, she sure was. She sure was. And you know what? We're all people with multiple degrees where, remember, nursing is a STEM profession. We have multiple degrees, high rates of great science background, everything. We all took microbiology probably more than once. I think there should be a microbiology course in all NP programs. But I'm going to keep that thought to myself because not everybody else agrees with me, but I really think there should be. And I found it confounding, sometimes confusing, sometimes annoying. And I understand why the general public who couldn't sort through a lot of the inconsistent information, why they then got a disdain for the CDC and overall increasing disdain for immunization. And so it's a tough situation that we're in right now. It really is. I'm putting together a program for my I'm going to present it in February and then again I think in May for a 2-day clinical update like this for FHEA. And I'm doing a program on to help clinicians learn how to identify measles, mumps, chicken pox, pertussis. What was the other? Oh, and avian flu. Because now avian flu, I'm going to push that to one side because that's not a vaccine preventable disease, but we're seeing it more in the United States. The others, like measles, mumps, German measles, chicken pox, whooping cough, they're vaccine preventable diseases, but our rates of kids being fully covered, let alone the adult population, is just dropping. We need to be able to recognize these better. So I want to thank you for joining me today. Thank you, Brittany, for your help, and we will see you all tomorrow. We'll run very similar to today, time-wise. Okay, thank you. Have a wonderful evening.